The topic for discussion is desquamative gingivitis. It's a peculiar condition that is characterized by intense erythema, desquamation, and ulceration of the free and attached gingiva. There is mild burning sensation to intense pain, and approximately 50% of the cases are localized to gingiva, whereas other cases may even have the involvement of gingiva and other intraoral and extraoral sites. In the picture, you can notice the chronic desquamative gingivitis case wherein there is irregular conspicuous erythema that is involving the free as well as the attached gingiva. So, around 75% of the cases have dermatologic genesis. So, the lichen planus and cicatricial pemphigoid constitute around 84% of the cases, whereas other mucocutaneous conditions like bullous pemphigoid, pemphigus vulgaris, linear immunoglobulin A disease, dermatitis herpetiformis, chronic ulcerative stomatitis, dermatomyositis are also responsible for causing the chronic desquamative gingivitis lesions. So, here in this picture, we will see the diagnostic approach that has to be followed for desquamative gingivitis. Clinical history is mandatory in order to begin the assessment of the desquamative gingivitis. We need to take the data regarding when the lesion has started, has it worsened, or is there any habit that is exacerbating the condition, and also if the patient has taken any previous therapy that has alleviated the condition should also be noted. Clinical examination has to be performed wherein we need to see whether the involvement only is within the gingival tissues or other intraoral and extraoral structures are involved or not. And Nikolsky's sign can be performed in order to assess the role of the vesiculobullous disorders. Biopsy can be done depending upon the extent and the number of lesions. Later, microscopic examination can be performed and direct immunofluorescence test can also be done. Once the diagnosis is established after all these procedures, then the treatment plan will be formulated. It is based on three factors. One is the practitioner's experience, second one is the systemic impact of the disease, and the third one is the systemic complications of the medications. So, in case there is systemic impact of the disease, the dentist will be collaborating with other healthcare provider in order to treat the patient and evaluate the patient. In case there are systemic complications of the medications, the patient is immediately referred to a dermatologist for further evaluation and treatment. Now we will see the conditions that are associated with the desquamative gingivitis lesions. The first one is lichen planus. So these are the diseases that clinically present as the desquamative gingivitis. So this lichen planus is an inflammatory mucocutaneous disorder that involves the mucosal surfaces. It involves oral cavity, genital tract and other mucosae, and also the skin including the scalp and the nails. So there are several clinical forms of oral lichen planus. The most common one is the reticular and the erosive subtype. So in the first picture you can notice the erosive lichen planus in which there is a large ulcerative lesion on the buccal mucosa, left buccal mucosa, and there is the bordering erythema that is seen, and typical white striations are seen in the periphery of the ulcer. So there is erythema and surrounding that erythema there are typical white striations. In second picture also is erosive lichen planus that is presenting as desquamative gingivitis. So we can see that the gingival tissues are erythematous ulcerated and this condition is very painful. Next, we will see the direct immunofluorescence staining of lichen planus. This picture shows fibrin deposits along the basement membrane exhibiting a shaggy configuration. In the second picture, we can see the clusters of the cytoid bodies. Next, we will see the histopathology of the lichen planus. This histopathologic picture shows the hyperkeratosis and mild hypergranulosis. There is focal basal cell degeneration, thickening of the basement membrane. Next, we will see the treatment algorithm of oral lichen planus. So, if the lesions are asymptomatic, if the keratotic lesions of oral lichen planus are asymptomatic, then there is no need for any treatment. However, follow-up for every 6 to 12 months is needed in order to monitor if there are any suspicious clinical changes or if this asymptomatic component is getting converted into erosive component. So in case if there is erosive bullous or ulcerative lesions, then high potency topical steroids have to be used. And we also need to assess if there is superimposed candidiasis. If candidiasis is present, antifungals have to be used. Then if large chronic ulcers are present, then intralesional steroids are used. Then you need to assess for the resolution. If resolution is present, we need to wear off and monitor, whereas if no resolution is seen, then the patient is referred to dermatologist. Next, we see the second condition, that is the pemphigoid. So, the term pemphigoid is applied to several cutaneous, immune-mediated and subepithelial bullous diseases. And this pemphigoid are characterized by separation of the basement membrane zone. So, this include the bullous pemphigoid, mucous membrane pemphigoid and pemphigoid gestationis. So in the first picture, you can see the coalescing cutaneous bullae and some of them are hemorrhagic. So rupture of these bullae lead to the formation of ulcers. In the second picture, we are seeing the gingival mucous membrane pemphigoid, in which the lesions are confined to the gingival tissues, producing a typical desquamative gingivitis appearance. In the third picture, we are seeing the symblepharon condition, typical ocular lesion that is seen in mucous membrane pemphigoid, in which there is adhesion of the eyelid to the eyeball. So there is ankyloblepharon also seen in some cases, wherein there is adhesion of the edges of the eyelids. This may lead to the narrowing of the palpebral fissures. Next, we see the histopathologic picture of the mucous membrane pemphigoid. So here in this picture, we can see that there is separation of the epithelium from the subjacent connective tissue that can be easily appreciated in the picture. Next, we see the treatment algorithm of the pemphigoid. So, in mucous membrane pemphigoid, the mainstay of the treatment is by topical steroids. So, we need to assess if the condition is asymptomatic, mild to moderate or severe. In severe cases, the patient is referred to dermatologist. In mild to moderate cases, steroids are used. If the patient is asymptomatic, proper plaque control measures have to be followed. Next condition is pemphigus vulgaris that clinically presents as desquamative gingivitis. So these pemphigus diseases are a group of autoimmune bullous disorders that produce cutaneous and mucous membrane blisters. So here in the first picture, you can see the characteristic cutaneous lesion on the wrist of the patient. In second picture, you can see the pemphigus vulgaris of the oral cavity, wherein you can notice the multiple ulcers which are also covered by the pseudomembrane. The next picture shows the pemphigus vulgaris of the gingiva, wherein the lesions are consistent with the desquamative gingivitis. Next, we see the histopathologic picture of pemphigus vulgaris. So herein we can notice the Zank cells, we can notice the tombstone appearance of the basal cells. Next, we see the treatment algorithm of pemphigus vulgaris. So the main therapy is with the help of corticosteroids and with or without the addition of other immunosuppressive agents. If the patient responds well to the corticosteroids, the dosage can be gradually reduced, but a low maintenance dosage is usually necessary in order to minimize the recurrence of the lesion. So minimizing oral irritation is very important in patients with oral pemphigus vulgaris. Optimal oral hygiene is essential because there is widespread involvement of the marginal and attached gingiva in case of pemphigus vulgaris. So, the periodontal care is an important issue in the overall management of the patients with pemphigus vulgaris. Next condition that clinically presents as desquamative gingivitis is chronic ulcerative stomatitis. So in this, there are chronic oral ulcerations and these are predominantly seen in the oral cavity. Only a few cases exhibit cutaneous lesions. So the treatment for this case is the usage of topical steroids and topical tetracycline, which produce the clinical improvement. However, recurrences are most common. In cases of severe conditions, high dose of systemic corticosteroids are needed in order to achieve the remission of the condition. The next condition is linear immunoglobulin A disease, and it is also called as linear immunoglobulin A dermatosis. So it is an uncommon mucocutaneous disorder and it mimics lichen planus both clinically as well as histologically. So how do we establish the diagnosis? Immunofluorescence studies are needed in order to establish the correct diagnosis. So here in the picture we can see the linear immunoglobulin A disease. There is intense erythema and ulceration that is consistent with the desquamative gingivitis. So the treatment of this condition is mainly by the combinations of sulfones and dapsone. So prednisone can be added if the initial response is inadequate, and alternatively tetracycline 2 gram per day combined with nicotinamide have shown promising results in such conditions. So recently mycophenolate combined with prednisolone has also resulted in resolution of the lesions that are refractory. The next condition is dermatitis herpetiformis. So it's a chronic condition. It is usually seen in young adults, and approximately 25% of the patients with celiac disease are having the dermatitis herpetiformis. That is, the dermatitis herpetiformis is a cutaneous manifestation of the celiac disease. So a gluten-free diet is essential for the treatment of celiac disease and the dermatitis herpetiformis. So oral dapsone is usually needed in newly detected dermatitis herpetiformis in order to alleviate the symptoms. The next condition that clinically presents as desquamative gingivitis is lupus erythematosus. It's an autoimmune disease. It has three different clinical presentations. The first one is systemic lupus erythematosus, that is SLE, and second one is chronic cutaneous lupus erythematosus, and the third one is subacute cutaneous lupus erythematosus. So here in the first picture you can see the characteristic butterfly pattern in SLE. So there's erythema on the bridge of the nose producing a characteristic butterfly pattern. In the second picture you can see multiple facial lesions and hyperpigmented borders are seen. In the next picture, we see the lupus erythematosus of the oral cavity, wherein there is intense erythema and also ulcerated lesions which are bordered by white radial lines. Next, we will learn about another condition called as erythema multiforme. It is an acute bullous and macular inflammatory mucocutaneous disease that affects mainly young adults 20 to 40 years of age and rarely children. So this picture you can observe the large shallow painful ulcers that are involving the labial mucosa and buccal mucosa. You can also see the crusting of the vermilion border of the lips in the mandible. The next one is drug related eruptions. So this is because of sensitivity to certain drugs. So because of this drug acting as allergen, there are oral lesions as well as the cutaneous lesions that are seen. So here in the picture you can see the erythematous gingiva consistent with the desquamative gingivitis. The other conditions that are associated that mimic the desquamative gingivitis are the squamous cell carcinoma, vaginous granulomatosis, candidiasis, graft versus host disease, Crohn's disease, and foreign body gingivitis. So, to summarize this topic, we need to understand that desquamative gingivitis has dermatologic genesis. Around 75% of the cases have dermatologic genesis. So there is mild burning sensation to intense pain, and mostly 50% of the cases are confined to the gingiva, whereas remaining cases are confined to the intraoral as well as the extraoral sites. So we have seen about the lichen planus, pemphigoid, pemphigus vulgaris, chronic ulcerative stomatitis, linear immunoglobulin A disease, dermatitis herpetiformis, erythematosus, lupus erythematosus, in which there are three forms, and we have also seen the drug related eruptions and other conditions that mimic the desquamative gingivitis. So the diagnostic approach is very important. Thorough clinical history has to be taken, oral examination has to be performed, microscopic examination, immunofluorescence has to be done in order to establish the proper diagnosis. Thank you everyone for your patient listening.